Hi, everybody. Mike Sokolowski. Thank you for joining today's educational call here at Hearts for Home Care. We are fortunate to be joined by two outstanding leaders in the home care advocacy space. Maggie DiPasquale, my colleague at Hearts for Home Care, and Patrick Harrison from the National Alliance for Care at Home. They are a great partner and lead organization in home care advocacy. As advocates, it is critical that we stay informed about the latest federal policies and reimbursement changes that impact the patients, caregivers, and families. Today's discussion is going to focus on recent home health updates, CMS Final Rule, including what these developments mean for access to care, provider sustainability, and future advocacy efforts. We appreciate Maggie and Patrick sharing their expertise and insights, and we hope this conversation will equip each of you with the knowledge needed to be even more effective voices for home care. Before I turn it over, be sure to visit our website and use the Share Your Story link. Stories from advocates are the most impactful, non-face-to-face meeting asset we have in our effort to make home care more sustainable and effective. With that, I'll turn it over to my good friend Maggie. Take it from here.
Thank you so much, everybody. Hi, I'm Maggie DiPasquale. I am the Area Director for Federal Affairs for Hearts for Home Care, and I'm excited today to kind of brief you a little bit on some home health advocacy opportunities coming up and why it is so important that we share our stories at this time. And then I'll kick it over to Patrick, and he'll go into some of the nitty-gritty about the rule and what is going to impact our caregivers and our patients, and just kind of the importance of why we share our voice right now. So earlier this month, CMS published a new proposed rule that would increase funding to Medicare home health services by 2.4%. CMS is the Center for Medicare and Medicaid Services. They are the overarching body that really dictates how much providers are funded for specific service lines. So we were really excited to see this increase in this recognition about the importance of the program. It's a positive step to a more stable funding environment, which is something that the industry has been advocating for about 5 years now. Home health has faced compounding cuts year after year, so CMS has been continually reducing the reimbursement rate. And while the rule increases our funding, there are changes in the proposed rule that would impact home health care recipients as well. So we want to make sure that we take this time to address our concerns there as well. So the proposed rule and advocacy. CMS does provide time for stakeholders to weigh in on the proposed rule through a few different methods. And now is the perfect time for advocates like yourselves to raise your voice and share your concerns for the people that determine the funding. They have provided this opportunity to listen, and it's important that we take advantage of it. So the first opportunity is August recess. So during the month of August, legislators in Congress take the time to head home to their home districts for about a 1-month break. So they will not be voting in Washington. They will be in their home districts, really seeing what's going on to the people that vote for them. This provides the perfect opportunity to educate them on these issues directly at home. So we encourage you to go to their offices, to go to events where you see they might be at. Just really share that I'm a constituent and this is concerning to me. There's also a comment period. CMS provides stakeholders 60 days to submit written concerns on a proposed rule. And this process is called comments. Comments are written by individuals like yourselves, organizations, companies that are concerned with the impacts of the rule. They can be as long as short as you want, and they can detail how this rule impacts you and why. And I think Patrick's going to go a little into depth about what makes a perfect comment, but it is a great opportunity to share exactly what is bothering you and what is concerning to you to the people that make the funding decisions. So what is the impact of this rule? Decreased funding equals access to care challenges for providers, for patients, for families. Funding levels directly impact how much care is able to be provided in the homes of people who rely on Medicare. Home health funding has been continually reduced by CMS, and hours of care provided have been decreased. Increased funding to Medicare home health will address the barriers that providers face in staffing and will help to increase the amount of care provided in the homes. CMS decides these funding levels. Through rules like this one, CMS determines the amount of funding for services like home health. And this funding impacts how much providers are able to pay caregivers. when the funding goes down and we have cuts to the reimbursement, then we are unable to increase the wages for our caregivers who so greatly deserve it. So it is important that we address this concern with CMS. And this rule will impact access to care. As funding cuts increase, providers struggle to recruit and retain the number of caregivers that are needed to provide care to everyone who wants to receive it in their home. I'm sure we're all familiar that people want to receive care in their home. That growth has really skyrocketed in the last 5 years. We've seen a lot more people who want to receive the care in their homes, but unfortunately, providers are just not able to get the caregivers in their home. And a large part of that is due to the funding that CMS has decided. So how can you get involved here? So Hearts for Home Care would love if you would meet directly with your legislators. We really encourage these in-district, in-person meetings. You can call or email their office to set up a time to meet and share your concerns directly with a staffer or with a legislator themselves while we're in this August recess period. And as Mike shared earlier, you can use the Share Your Story platform. We are happy to distribute stories to legislators that you are able to submit on the Hearts for Home Care website. Those are great clips and videos, and we can share your story directly with those people as well if you don't feel comfortable or if you are unable to meet with your legislator in the district. All right. And then my contact information is here. If you would like to get involved with Hearts for Home Care further, if you would like to set up these meetings, we are here to help. We want to make this as easy as possible for you to get involved. Patrick is going to give you some more details about how to get involved and about writing comments, but we are here to help you as well. I'm happy to provide contact information for addresses of district offices or phone numbers or emails. We have fact sheets with the data and with the ask. I know sometimes it feels more comfortable to have something in your hand while you're having these conversations. So we have helpful fact sheets for that, talking points to get you to making the ask and getting more comfortable with making that direct request of a legislator, and templates for requesting meetings, whether you call the district office or you want to email. We are able to help you however you want, and we're happy to help. And we really do encourage you to reach out to us if you want some of these resources. All right, so that is all that I have for today. I will kick it over to Patrick. He's going to discuss exactly how this rule will impact home health beneficiaries and some more ways to get involved.
Thank you, Maggie. And that's great to hear about the resources, the one-page materials there. I'm a visual person. I like pictures. I like simple things, as my wife likes to make fun of me for. So, again, that's so helpful as we think about having these conversations, as we work to advocate for this access. And one of the common things we'll be talking about today, indeed, is the access that Maggie so emphasized earlier. We are dependent on sufficient rates from Medicare to ensure that we can continue serving our communities, meeting community needs, that our staff, our agencies, and that our clients and individuals in the community can continue to benefit and receive and engage with this important benefit. So as we'll go on to the next slide here, just tell you a little bit briefly about myself and the Alliance. My name is Patrick Harrison. I'm the Vice President of Managed Care and Innovation Policy at the National Alliance for Care at Home. This is an organization that formally emerged a few years ago from two longstanding prior organizations in the national space. And we are the largest organization representing, advocating for, educating, and connecting providers delivering care in the home. We work with over 10,000 organizations, which includes a workforce of over 2 million patients, caregivers, clients, and so forth. And again, I want to take a moment really to acknowledge all that you have done and are continuing to do yourselves in your communities and so forth. It's the fact that you are here tells me how important this is to the work that you do and what you're doing as well. So moving on here, I want to talk a little bit about the federal policy landscape and more importantly about the home health landscape on the next slide that we find ourselves in at this point in time. As I'm sure Maggie can speak a lot about this more than I can here, this is a very pivotal time in Washington with all that is happening in our space. And there's, for better or for worse, we have seen an instance where home health, more broadly care at home, is getting a lot of attention. And some of it's good attention, some of it's bad attention from the specter of fraud and program integrity, which I'll talk about a little bit later on this call. But we are at a point where we realize, hey, this is a critical benefit that provides valuable care. And as Maggie mentioned earlier, we know that individuals overwhelmingly prefer to receive care, high quality care, in the home, wherever home may be. And what we are seeing from the past several years is a steady decline in real dollars, in visits, service capacity. And you heard Maggie speak about the fact that as agencies, we are dependent on these federal Medicare dollars to be able to attract and retain a skilled and robust workforce that are necessary to continue meeting community needs. And indeed, the U.S. population, age 85 and older in particular, is actually expected to triple from 2020 through 2060 to over 19 million individuals. Over one-third of individuals age 85 and above report being free of a disability or have difficulties with ADLs, activities of daily living. And caregiver support ratios are continuing to decline across most regions. We've also seen a new law that went into effect in 2020 that implemented a new Medicare payment system for home health, which, while well-intentioned, has led to a number of considerable challenges that the industry has faced and ultimately impairs our ability to, again, to have that workforce that Maggie mentioned, to be able to expand our reach, to work with clients, work with caregivers, and ensure that ultimately individuals receive the care in the home that they depend on, need, and overwhelmingly prefer. Some of the specters we are facing, we continue to face $4.9 billion in outstanding dollars in overpayments that CMS, the federal agency that exercises oversight over home health agencies, plans to take back over the coming years. I mentioned declining visits. We have seen rising costs. For example, gas prices are on the rise. As we drive, as we provide care in various homes, agencies and workers have to cover those gas costs. And that is one example of many of the rising cost pressures that we face that, again, challenges abilities to provide timely care, timely services in the home, which are so instrumental to what we do. Take a step back as well here, and I'm going to talk a little bit about the broader policy climate a little bit here. So bear with me. We've talked a little bit about Congress, and again, there was a law that came into effect 2020. We also have with Congress what's called the Medicare Payment Advisory Commission. It is an entity that advises Congress on Medicare payment policy. And we have also seen a continued narrative from the Medicare Payment Advisory Commission, otherwise known as MedPAC, that home health payments are fine, that access is fine, that there are no issues, and that we actually should reduce payments even further. As we know here, that misses the reality on the ground level. And again, I want to kind of hammer home this point on the slide here. We know that individuals overwhelmingly prefer to receive care. We see continued positive outcomes associated with receiving home health care in the home. And on the flip side, we have seen research out there demonstrating that when individuals are referred for home health care and they don't timely receive that care, that leads to serious and adverse consequences for individuals, for families, for caregivers. And we're involved, and we see higher mortality rates. We see increased hospital readmission rates. We see decreased function, mobility, and ultimately autonomy to be able to independently remain in the home. These are ongoing challenges that we are working to address, and indeed why your work here, your engagement here is absolutely critical to ensuring the continued viability of this benefit, and that that it actually has the resources necessary to accomplish what it was intended to do. So if I were to say one thing here, demand is not the constraint here. As Maggie mentioned, demand is rising. Our resources and reimbursement is the challenge we continue to face that, again, is getting in the way of ultimate access and ensuring that we continue serving our communities. And the next slide demonstrates here, again, I am a visual person, but this is just a chart showing overall access to home health services. Now, I will preface here a little bit that there has been a lot of fraud in the benefit, and I'll talk about that a little bit later here. But that fraud has been overwhelmingly concentrated in certain areas, particularly in Los Angeles County, California. Overall, when you look at the big picture here of home health agencies, we are seeing a continued decline in the number of agencies actually providing care. This is not theoretical. This is access shrinking in real time. And since 2019, we have seen over 1,000 home health agency closures, which ultimately means 1,000 less agencies that can no longer serve their communities. Fewer providers, fewer agencies here means longer wait times, more non-admissions. Individuals who receive delayed care and may have to go back to the hospital, or working in the home by yourself without that essential support from clinicians, from staff in the agencies, from aides and so forth, and everyone who's involved in this service delivery. So we know that there is an access problem. And this is our overarching goal. This is our North Star that we are working to achieve, to ensure that individuals, that clients, that community, persons in our community have access to high quality care in the home when they need it, that will, in a way that's preferred and provides important benefit. So that takes us to the 2027 Home Health Proposed Rule. And you see CY here. Apologies for the acronyms. I'm notorious for this a little bit. CY stands for calendar year, but when you hear me talking about years here, and we're talking about the year 2027. Again, as we've talked about, home health is under significant financial and operational strain. We've seen years of policy changes layered on top of multiple cuts, on top of inflation and workforce challenges. And the result is a system that is increasingly strained. And home health, when you think about it, this is a benefit that provides a lifeline to our individuals and communities. This is a way that, in theory, should be able to solve a lot of society healthcare problems, allow individuals to remain in the home, allow them to recover, receive skilled care in a way that makes sense, is economically feasible, is cost effective, and drives quality outcomes. But again, given the lack of investment, the lack of support into this benefit, we have seen challenges for the last several years in particular. As Maggie alluded to, though, we are for the first time seeing an increase, which is welcome news. But that's just the start, and there's a lot more work to be done yet. And so as we move on here to the next slide, I'll talk about this just a little bit. So for 2027, again, this rule came out early this month, as mentioned, on July 1st. You can find, for those who like to look at rules or would like some delightful bedtime reading, you can certainly click the link there on this slide, and you can peruse the long regulation, a long rule there. I will note that comments on that rule are being accepted through August 31st, next month. It's amazing how August is already almost here. So again, rule came out on July 1st. Comments are due on August 31st. And I really want to hammer home Maggie's point there about this. Your voice absolutely matters. Believe it or not, it does make a difference. We at the national level work very close with agencies nationwide to provide a unified voice, highlighting challenges, advocating for sufficient access. But ultimately, individuals like you have that perspective, have that ground level experience that is so critical and so important that can help actually drive some of these changes here. So in this year, we see a proposal to increase payments to home health agencies by 2.4%. And that's about $420 million. We also, in the rule, see a number of changes as well. I'm not going to go into all of these today, but suffice to say, in the rule, there's a discussion on palliative care in the home health benefit. For example, CMS believes that home health can be a vehicle to provide palliative care. That's, again, a critical benefit, but without the resources necessary to continue to carry out that care, that creates problems. There's also changes to quality reporting program. There's some significant provider and program integrity changes that I'll touch on momentarily, along with some other considerations here. But for our purposes, we're going to be really focused on the financial considerations, the impacts here, which get to the workforce issues and others that Maggie mentioned. We're also going to talk a bit about the program integrity piece. So here you see in a slide a lot of numbers. I'm a lawyer. As they say, people go to law school because they fail math. But I'll just preface that a little bit here. But I do want to take a moment just to, before I dive in, to talk a little bit about how we got to where we are today. So for those who love history, great. This will be fun for you. For those who don't, I will be brief. Now, go back in time with me, if you will, to several years ago, and there was a law passed by Congress called the Bipartisan Budget Act of 2018. And in that law, Congress directed CMS, again, that federal agency responsible for the oversight of the Medicare home health benefit, to make changes to the Medicare home health payment system. And Congress required that transition to be budget neutral. And that's a bit of a buzzword in the health policy community. What I mean by budget neutral is that payments could not be higher under the new system relative to the old system. So in response to that, that federal agency, CMS, made a number of assumptions about how providers would respond to that change. Now, when there are differences, the agency has generally two options here. There may be, they can implement what's called a permanent adjustment or a temporary adjustment. And permanent adjustments change the payment rate going forward. And that's perspective, and that's a very, that's compounding. It's permanent and compounding. Temporary adjustments claw back. They take back money, what CMS believes has already been overpaid. Now, I'm not going to go into the details further because it gets really weedy here. Suffice to say, in last year's rule, CMS initially proposed a 6% cut. Again, this is a 6% cut at a time when the industry is facing insurmountable rising cost pressures along with workforce pressures. We were successful. The industry broadly was successful in getting that cut reduced. And we argued that, among other things, that CMS was inappropriately considering factors that weren't relevant to that adjustment or to the imposition of those reductions. CMS agreed with us in part, at least for calendar year 2023 and beyond. So good news here for 2027 is that we do have a positive payment increase for the first time in several years. And again, that's good news. And that really is a sigh of breath relief. I mean, think of an individual who's treading water. We're at the point where you can finally get up in there and take a breath. But it's not, but we're still in the midst of the ocean here. We still got to swim. We still got to make waves here. So we still have a lot of work to do. And while we are still seeing an increase overall, CMS is also proposing to cut home health rates by 3% next year. This is a temporary adjustment I was alluding to, for the second year in a row on top of prior reductions to take back money that the agency believes was overpaid years ago. That cut is worth about $500 million. That's a lot of money. So when you think about this, without that 3%, home health agencies were set to receive about $900 million more next year instead of $420 million. That is money. Those are federal dollars that could help agencies to better meet community needs. These are dollars that could directly translate to be able to serve more communities, expand our reach, work with more clients, hire more caregivers. But that is a significant reduction in that even though we are seeing an increase, that reduction impairs our ability to continue doing what the benefit was intended to do. So this is where your voice really comes in here. And again, to add more fuel to the fire here, this is only recovering about 10% of about a $4.9 billion in outstanding payments that CMS believes is owed. What that means is that if CMS takes back 3% every single year, we have another decade to go. Again, not while we've got a breath of fresh air here. We've got a lot of swimming to do here to get out of the deep end. And we also know, again, as we previously shared, clients, individuals overwhelmingly prefer to receive care. I want to shift gears here a little bit. So we talked a little bit about payment. I also want to talk about another piece here, and that's, as we'll see in the next slide, we're seeing a lot of provider enrollment proposal. And that's a bit of a weedy topic, so I'm going to break this down a little bit. Bear with me. Take a step back with me, if you will, over the last couple of years. And we have seen in particular a number of fraudulent activity occurring in the Medicare home health benefit. There's also been other elsewhere as well. We've seen it in hospice, we've seen it elsewhere too. But this is something we have seen, particularly, and I mentioned Los Angeles County as one geographic hotspot. That fraud is ultimately hurting beneficiaries, hurting individuals who depend on this care. It's also hurting providers who are operating in good faith, who are legitimate and actually working to meet community needs. It's hurting staff who are engaging with clients, engaging with these individuals, and ultimately have to contend with a new image that home health is a fraudulent benefit. We all know that's not true. And while we absolutely want to stop bad actors from entering the benefit, we want to protect the integrity of this benefit and individuals who receive care and deserve to receive that care. The narrative we've seen in response to that fraudulent activity has been one of excessive, I'm using the term excessive in my view here, oversight. And what that means is that CMS is now proposing to include a number of changes in that rule that can also have an adverse impact on access. Again, there's that access buzzword, which is our North Star as we think about our work here today. And in this rule, and let me take a step back further here. When to participate in the Medicare program, a provider essentially needs to sign an agreement. You've got to agree to follow certain laws, follow certain requirements, do certain practices. There's what's called conditions of participation, among other different factors there. So think of this as you are partnering with the federal government to participate in the Medicare program. And there is there's no enrollment process as part of that effort. Well, what's happening here in this rule is that CMS is proposing a number of significant changes that really put challenges on that enrollment process. The Alliance itself, the National Alliance for Care at Home, my organization, we have advocated for program integrity measures that would protect individuals, protect patients and clients, and hold bad actors accountable through targeted, data-driven enforcement without restricting access or harming legitimate providers. We are concerned, however, about these particular provisions that they go too far. And what we see here is a number of changes where CMS is giving itself arguably unchecked authority to go after providers, even legitimate providers, who may make inadvertent mistakes, who make omissions or otherwise, and deny their ability to participate in the Medicare program. Again, I said there was an agreement that a provider needs to engage in to work with Medicare, particularly. There's a lot of these in the rule. I'm not going to go into a lot of these. I'll highlight just a few examples here. But CMS may deny Medicare enrollment for a provider because their practice location is in the same suite or office as a different provider who had their enrollment revoked or denied. Anyone here been to a doctor's office or an area where there's a lot of different offices in one building? Do you ultimately, we typically don't know what's happening with that provider on the third floor, the fourth suite, or otherwise. And it would take a lot of effort to find out what's actually happening there and was their licensure revoked? What are they participating? Needless to say, just by proximity, just by location, CMS is proposing to deny provider enrollment and ability to participate in the Medicare program. Also, CMS may deny enrollment because even a compliant, legitimate provider is located in a geographic area that has an excessive number of providers and suppliers. Well, what does excessive mean? You've seen one agency, you've one selling service, you've seen one, as the saying goes here. And as we all know, communities have different needs, different reach. And talking back to that area where we are driving from across the state or driving across the region to provide care, that's different reach, different mileage, different service areas. So when CMS describes we can deny enrollment in the Medicare program based on an excessive number of providers, that doesn't provide a lot of confidence to us of how the agency will actually handle that, and ultimately creates risk and impairs access to individuals who depend on those providers and agencies. There's also another example here I'll highlight very briefly is that currently there isn't a bar on enrollment applications that applies in instances where an entity submitted false or misleading information. In other words, they were actually fraudulent. Well, and that's a 10-year bar, meaning that for 10 years, an entity cannot participate in the Medicare program and serve Medicare beneficiaries. CMS is proposing to extend that to generally any denial reason permitted under regulation. I made a mistake and omitted one individual on the enrollment application. I made a typo. I did something there that gets the application rejected or denied. These, and while CMS indicates that they exercise discretion, this has the impact on access because while barred, not able to enroll in a program, a provider cannot order, cannot certify, or prescribe Medicare covered services or beneficiaries. Again, this gets to that access North Star that we are talking about. So this takes us to the next slide here. And you've heard me use a term a lot, proposal. Well, what does proposal actually mean? In the rule process, in the typical rule cycle, CMS is proposing a rule to solicit feedback, as Maggie mentioned, from stakeholders, from those in the community, from providers and so forth, to determine whether this is the right path forward. Okay, let's say I'm CMS. I'm going to propose these changes. I think this is the right thing to do based on whatever factors. But industry, I want to hear from you. Okay, this is what I think is the right thing. What do you think? Should we do this? Should we go this route? Are there changes I need to make? Should I pull certain proposals back? So when I say proposal, it's not final. It's what CMS plans to do, but may make changes into later what's called a final rule. And that's where CMS ultimately implements in regulation, final regulations, policies, and so forth. And so one of our goals here is to secure a better outcome in this final rule. I mentioned there's about 4.7 or so billion in temporary negative payment adjustments still outstanding. Again, assuming 3% cut every year, that means the industry will face 10 years of cuts, additional cuts. We have a lot of concerns with how the CMS made these calculations. And we are working with the agency to correct flaws in its approach. We're also engaging additional meetings with CMS and the administration here. Look, there's some problems here. Access is a real concern. There's issues with the data. And working, of course, with congressional offices to amplify advocacy. I'll give one example here, and this is a very recent development, is we are working with Senator Collins' office in Maine to introduce a bill called the Medicare Home Health Payment Integrity and Fraud Victim Act that would actually reset Medicare home health rates in 2027 as if permanent cuts were never applied and would prevent any future temporary or permanent takebacks from the Medicare home health rates. In other words, this would really restore us whole to whole, or as intended to do. It would also include several common sense program integrity reforms, such as enhanced oversight screening, ensuring that providers are legitimate when they actually are enrolling in the Medicare program, more frequent surveys of new agencies, and increased oversight of agencies that don't report, for example, certain quality data or metrics, among other different things there. But this is one example that we are working on. But this also, and again, we also want to ensure common sense parliamentary reforms. We all agree we want to stop fraudulent actions. We want to protect the integrity of this benefit. But we need to do so in a way that doesn't impair access, that ensures that individuals, consumers, stakeholders, clients continue to receive those services that are so important. But this, going back to Maggie's comments there too, this is where your voice is so instrumental in district level meetings, providing comments, providing feedback. Your voice matters. I'm not the expert here. You folks are. You're on the ground. You're on the boots on the ground approach. You are in the weeds here working this every single day. You know what it's like when happens when you can't get to that client. Right. If you're a client, you know what it's like having to work with them, with the caregivers, and what happens if there are delays or challenges there. This is where your voice is so important. So I want to take a moment here to talk a little bit about some strategies for submitting comments. Again, this is one among many efforts of advocacy. There's grassroots, there's working with congressional district offices, as Maggie mentioned. Submitting comments on a rule is just one additional avenue there.
Hey, Patrick, I'm going to, for 1 second, pause here.
Sure.
I'm going to let everyone know on the right side, there's a chat feature. You put your questions in there, comments. Then you could also use advocacy@heartsforhomecare.com as an email to send any questions later that you have for either Maggie or Patrick, and they will get back to you directly if you just go through advocacy@heartsforhomecare.com. And again, for those that weren't on in the beginning, you could always go to the website, heartsforhomecare.com. And when you do, you're able to go in there, and there's a share your story link that I mentioned in the beginning. And that allows you to put your technical background, if you're a client, if you're a provider, if you're a caregiver, and let us know why you advocate for home care. But these are the best practices for sharing those links with us. And again, you can send an email to advocacy@heartsforhomecare.com if you don't have the question right now, but you think of something later. All right. And with that, I'm going to send it back to my friend Patrick.
All right. Sorry, folks, for the technical delay issues there. Again, as folks who know me at the Alliance, technology and I do not get along. And it appears that story is continuing today. Hopefully, we'll get through this without any more issues there. So moving forward here, I'm going to talk about some strategies. I want to be mindful of our time to ensure we can have questions as well. But I'm going to talk a little bit about how you can submit comments in response to this rule. So if we go forward to the next slide here, just very briefly, again, we've talked a little bit about program integrity, so I'm going to skip over some of this here. Again, there's been the specter of oversight. We know those challenges there. And as I shared in the next, we also, in response to that program integrity climate, we have the imposition of a nationwide moratorium, which means that no new provider can enroll in the Medicare program, and that's in the home health, and that's nationwide. Again, while we support targeted solutions here, as you see in the next slide, we are concerned about the broader impact on access. So moving on to some comment strategies here, I'm going to talk through some opportunities here. First off, when individuals hear comment, I immediately hear, and it can be overwhelming. You see this big rule, you see all this text on the screen, several hundred pages. Like, what am I going to do? No, I'm not going to do that. And this is actually a very simple process. You don't even have to put together a document. You don't have to do any of that. And it's a very, very easy to submit a comment. I do include some instructions here on this slide, but again, the links are listed there. A docket number is essentially how the federal government tracks different rules and regulations, so you can search for that docket number there. In the bottom right of the screen, you'll see a picture of what comes up when you search for that. You want to click on that comment button there in the bottom right, and there's also a direct link listed there in a slide. So moving on from that, this gets us to the ultimate question. How do we write an effective comment? One thing I want to emphasize and make very clear, I have seen incredible comments written that were 1 or 2 paragraphs long. I have also seen very poor comments that were 40 or 50 pages long. You do not need to put a lot of work into this. It does not take a lot of time. What really matters is the fact that you're putting your voice and sharing your perspectives and really talking about these issues that are so important. Before I kind of set the stage and talk through this, I want to take a moment to kind of ask you, when you're approaching a comment, the first question to always ask yourself is, why is home health important to you? Why is home health important to me? Because that only is going to drive what you are going to be writing. And again, I talk about the access considerations as well. But one thing you'll want to do is talk through, first, just introduce yourself. And that can be one sentence. Who are you, and why are you commenting? Why should CMS listen to you? Also, it can be helpful to identify what actually you are commenting on. I am commenting on home health cuts. I am commenting on payment. This does not have to be nitty gritty or pointing out the specific regulation. I'll do that at the federal level. You don't have to. This is really identifying the specific proposal or even general topics that you are concerned about. And it can even not be concerned. There could be things you support here, like CMS, I think you really should do this one thing. And also, you want to talk about who you are, why you're commenting, what are you talking about, and describe how this is actually going to impact you. Let's say CMS moves forward with payment cuts. How is that going to impact you as an individual, as an organization? And then it's helpful to pair this with a recommendation. What should CMS do instead? Do not finalize negative cuts. Again, it can be very simple. I mean, these little bullet points here can be all done in 5 sentences or just a couple paragraphs. It can be very, very quick. One thing I just suggest here is you can be specific, provide your recommendation, and if you disagree with the recommendation, again, state an alternative here. What should CMS do instead? One thing I do want to emphasize is that's to be professional. Many proposals out there, even if leading to really harmful results, are arguably well-intentioned. And we want to be good stakeholders in this process. We want to kind of work with the industry and support and collaborative here. So I'd really emphasize just be professional and respectful. Comments also are a matter of public record. Anything you do post can be searchable. So just keep that tone civil and avoid that inflammatory language, even if we are really passionate. And as some folks know, I can be very passionate. I've certainly been that at times, and I will have to stop myself from doing so here. But and what I will also share for the providers and staff of providers in the room. Keep in mind, HIPAA still applies here. You should not be sharing protected health information in your comment, which again is a matter of public. Again, all for suggestions, not criticism. We want to be constructive here while also being effective in our response. So moving on to the next slide, we see some tips here. Again, start early. I've worked with many individuals, consumers, and stakeholders who had a great letter or had a great couple of paragraphs, things they wanted to share, and they just forgot to submit it. They waited till the last minute and they missed the deadline. So start early. Also, again, this is where it helps to be concise. Longer comments are not necessarily more effective. Being very concise and articulate as to what specific about what issues you are opining on can be very effective here. Again, we don't need to hear from, so we are not looking for some reputable journal, some other like that. This is where your experiences really matter. We at the national level be looking at some of the evidence, look at some of the, to all the kind of the policy wonk type of issues there. But what matters is, what are your strengths? What are your perspectives? What can you leverage in support of your arguments? And that's where supporting your claims comes in. Again, it doesn't have to be journals. It doesn't have to be data. It can be your own experience. While again, for private providers in the room, don't share protected health information. Identify the issue there. And again, as I mentioned, be constructive. Alternatives, provide suggestions there. If I start by laying out my concerns without really noting what I'm responding to, it can sometimes be, think of from the perspective of the CMS reader or their contractor. We want to make their job easier as well. And remember ultimately that there is a reason why CMS is taking these actions. CMS is cutting home health rates because they believe this is what they are instructed to do under the statute. We disagree. We think they've made mistakes there, but there's a reason for that. There's also the reason why they're proposing those program integrity provisions. They're doing it to stop fraud, well-intentioned, but we believe it goes too far and can hurt access. And again, there is no minimum or maximum length. As I shared, I've seen incredibly effective comments that were 2 paragraphs long. And you, as you go on this, as you click on the link I shared previously, there's actually even a text box where you can type your comment directly on the page itself. You don't need to submit your own separate document. But moving on from there, again, I want to talk a little bit here briefly about some grassroots, amplify the impact here. Again, this is where our collective voice makes such a difference. Every action together, we are singing the same tune. We amplify our voices together. As Maggie mentioned, meeting with your district offices, sharing your voice to your delegation. Coordinated advocacy ensures that our policymakers hear your stories, and your stories is ultimately what really matters. And every action here helps to build that momentum to, again, achieve that North Star of ensuring sufficient access. Moving on to our advocacy, I want to take a moment to talk about this. We do host an annual fly-in. And what I mean by flying is we bring in providers, stakeholders out to Washington, D.C. to meet with congressional delegations across the District of Columbia. And we are holding this year's annual Advocacy Week on September 13th to 16th, where we bring together home care leaders, providers, caregivers, volunteers, and advocates from across the entire nation. And this is where we come together to speak on one unified voice on behalf of the industry, and importantly, the individuals and clients we serve and work with very closely. This Advocacy Week, we have a number of resources there available. As Maggie mentioned earlier, in terms of one-pages resources, we also provide a number of tools, training, and so forth to help equip you to actually engage with various congressional offices. We, on the 13th, we're holding a welcome reception just to engage with other peers, colleagues, and community. We also hold a beginner advocate training. Again, we've had many first-time advocates come out. Those who've never stepped foot in a district office or congressional office before had a chance to actually meet with their congressional office. And in fact, I went on a visit last year where this individual was their very first time. And lo and behold, the Congress person themselves, the senator themselves actually met with this individual, this constituent, because they wanted to hear from them. They didn't want to hear from me. They wanted to hear from that individual who was a constituent in their community. So we hold beginner advocate training to help equip you for that. We have a Hill Day briefing and prep. And again, we have Hill Day meetings, our Capitol meetings on the Tuesday the 15th. Encouraged to look into this. Highly encourage participation, as Maggie knows. And to that effort, we've also offered a number of resources as well. In response to Rule last year, we launched a home health rule landing page. This is being updated for this year's rule as well. You can see some pictures there on the slide. We include a lot of one-pages materials, facts, data points that can be helpful as you tell your story, as you talk through why home health is so important to what you do every day. And with Maggie, I'll turn it back over to you there.
Thank you, Patrick. That was really great. I think it's really important to stress the value of comments and sharing your opinion and your voice, no matter how long or short your comments might be. So if you are interested in submitting comments, please reach out to Mike or I, and we are happy to help you there.
Thank you very much, everybody, for joining. Patrick and Maggie, thank you for being wonderful guests. And as always, if you're watching this as a recording, email advocacy@heartsforhomecare.com with any questions, and we will get them directly to Patrick and Maggie. Patrick, Maggie, and I will see you in Washington on the 13th, and we hope you have a great rest of your summer.
Bye, everybody.
Looking forward to it. Thank you.